and transitions, medical care, post-acute care, and community care. And our moderator for the day is Karen Grimsich, who is the administrator for the City of Fremont's Aging and Family Services Division, which serves the entire Tri-City community. And I'll point out to you that Karen's bio is in the program, so you can find out a lot more about her. Welcome, Karen. I'm really glad that you're here to moderate the panel. The floor is yours.
Thanks, Wendy. So obviously that's a pretty tough presentation to follow. I think we're all feeling a little heavy from that, but I think it's important that we're all together in this room and in trying to envision some solutions and things we can do better. So as far as my panel, they're listed up here, and again, as Wendy said, there's a full bio in your program, so I'm just going to be very brief, but we do have Austin Ord, who will speak first, and he's the Director of Post-Acute Care for the Sutter Health Bay Area, and Jamie Almanza, who's Executive Director of Bay Area Community Services, and then Corinne Jan, who's Executive Director of Family Bridges. So the panel that we've put together today is to explore, and again, we'll be taking questions, so write down on your cards, but this kind of land, this territory between where healthcare and community-based services intersect. And I think this is where we, as a county, as a service provider, as a health plan, need to be focusing our energy. No matter what changes we're facing in the future, we can work better together. So we're going to be looking at this through the lens of the hospital and service providers and focusing mostly on post-acute care and the hospital-to-home transition. This is when things are very complex, as everyone here knows. So we've asked everyone to present a little bit, 10 minutes each first, and kind of talking about their perspective of working together, promising approaches that kind of support people transitioning or interacting with both care systems, and kind of understand openly with all of us here, and your questions included, on how we can work together now, but how we can work together more in the future. So again, write down your cards. Wendy will be collecting them. We'll kind of do Q&A at the end. But I'm just going to turn it right over to Austin here and his slides and get started.
Good morning. Thank you, Karen. Hi, I'm the Director of Post-Acute Care for the Sutter Health Bay Area. In my role, I interact with many levels of care, skilled nursing facilities, home health agencies, durable medical equipment providers, you name it. I'm usually out if it involves some kind of medical need following a hospital discharge. But today I'm going to be speaking from the perspective of hospitals. I understand it's hard to understand how hospitals operate from the community-based perspective. So I want to give some insight into how it is difficult for us to operate and maybe hopefully convey some lessons learned or opportunities for better collaboration in the future. So I do think there's opportunity across the full care continuum for better collaboration, but today I'm just going to talk from the hospital perspective. So I do want to preface, I'm kind of an economics nerd, so I think it's important to maybe give a little bit of a foundation, because I think it nicely describes the challenges of where we're coming from. So I think the basics of economics are that people will utilize a finite, limited number of resources to make decisions to maximize their outcomes. In short, people respond to incentives, right? Healthcare, this principle is universal. There's positive incentives and negative incentives. Black Friday sales, positive incentives. Sales come out, encourage people to come out, do crazy things to each other to get 50% off a TV. Another example, negative incentives. The soda tax, for instance, that just passed here in the Bay Area. Strap on a little bit of an extra charge to dissuade would-be sugary beverage drinkers. These are ideas of incentives. Healthcare is no exception from incentives. The problem, though, is that there are so many different, let me back up a second. In healthcare, incentives take the form of payment methodologies. We get reimbursed 1,000 different ways for 1,000 different types of services, and it's very hard to think straight because things are coming at us very quickly. These are some of our common, pardon me, they're not all up there. I had a few more listed in my other PowerPoint. There's a ton. At the bottom, I just have 2 here, but there's several different types of payment methodologies that we work with just on the hospital setting. what I'm getting at is that these incentives drive behavior. Historically, we operated on per diem reimbursement or percent of charge reimbursement. These encouraged us as hospitals to keep patients for as long as we could, which drove up costs. The longer a patient stayed, the more expensive it was, but we would command a higher reimbursement. Currently, we work in a DRG or fee-for-service model. Right now, this means that we as a provider will want to do as much as we can, as quickly as we can. So this leads to some concerns on quality. In these models, there's not incentive or resources to really focus beyond what happens inside the four walls of the hospital. It's just the reality of the fact. It's the world that we live in. When patients leave, we care about them, we want them to do well, but we're focused inside, do as much as you can, as quickly as we can. We're moving now into a different world where we are moving into episodic payment models and capitation. They were listed up here, I promise, but basically this means that we're shifting risk to hospitals. So that's where we get into this slide. If you look on the left side, we have the employers, government payers, and health plans. When I talk about risk, I mean risk for spending. So historically, employers through employer-sponsored health plans, government payers through Medicare and Medi-Cal, and health plans had the risk for spending. If we spent more money as a provider, they were the ones who lost. Now we're moving into a world where hospitals and physicians and providers have the risk. So if we overspend or do a poor quality job, we're the ones who lose. This is new. We're in the middle right now. We're shifting into this world where we have to do a really good job. It can't be rushed. It can't be too much too quickly. It has to be just the right amount and just the right needs of the patient to really make sure that they have good outcomes beyond their hospital stay. This is new for us, and I think it's really exciting. That's why my job got created. I'm the first one of my kind to look beyond the four walls and look at collaborating and make sure that when patients leave the hospital, they're set up for success. So we're somewhere in the middle. Bundled episodic payments are a new emerging trend. I'm not going to go into detail because that'll be boring. I kind of got away lucky with an economic speech already, but the point of the story is that we now have risks, so we are finally doing, I think, what is considered the right thing. We have to do a good job. We can't just do high volume really quick anymore. We have to have some value for patients. We have to start collaborating, not just more on the community-based perspective later, but also with our skilled nursing facilities. We have to set them up for success. We have to set up our home health agencies for success. We have to do the right thing to make sure patients are succeeding beyond the hospital discharge. And we're slowly starting to connect with non-traditional providers, and I'm excited to have Jamie next to me because we have a cool program to talk about. So, now, industry-wide, this is not specific to Sutter, although I come from Sutter, there are impacts to hospital discharge planning. The top three metrics right now that are at the forefront, I'm just speaking current state, this is starting to, this probably will always be a concern, at least for the near future. Top three metrics we care about are length of stay, length of stay, length of stay. That's the matter of the fact right now. How long the patients stay in the hospital directly equates to our cost. So that we're trying to get them out quickly. The point of the story is patients are leaving the hospital setting more acute than ever before. Our previous keynote speaker just alluded to that. It's what we're working with. We're also now penalized for readmission, so we can't push them out too quickly. We care about safety too. I want that to be a message that is heard. Patients, if they're pushed out with the tubes, that example was horrible. That's not the rule. That makes me a little bit sick. I'm not here to say that we're pushing people out while they're still bleeding. But we are discharging them earlier than ever before. So it's helpful to know as a community-based organizations that people are leaving the hospital earlier than they have in the past. And there's also now, because we're moving into this new bundle payment environment, an increased need to coordinate beyond the hospital discharge throughout the care continuum. So this means that a partnership like we have with BACSET, which you're going to talk about a little bit more, it's helpful if a community-based organization can help us manage a more acutely ill patient. We also need to partner from the readmissions perspective that can help us manage medical or psychosocial needs to avoid sending them back to the hospital, rather connecting them with community health resources where they are better served. People don't want to be in the hospital, and they shouldn't be in the hospital. It's not fun. It's not safe. And we also need people who can help us transition patients through the care continuum to appropriate setting. That's kind of the need from a partnership from our perspective. Now, the problem that we work with in hospital is case managers. People making discharge plan are hospital case managers. I'm sure all of you know that. They are wonderful, smart, lovely, talented people that are so strapped for time. They have a lot to do. So on average, they manage about 20 patients, and they're checking for things like, what medications is this patient on? What were they on before the hospital? What are they on after the hospital? How is this going to impact them? Where's their pharmacy? What's their insurance? What benefits do they have? What do they have to pay for out of pocket? Can they walk? What's their functional status? Do they have stairs? How are they going to get home? Wait, do they have a car? Can they even get home? How are they getting to the bus? Can they afford the bus? Can they walk to the bus? Oh, a wheelchair, that's crazy. Do they have a home even? Why am I talking about home? Let me back up further. Do they have family? Who can care for them? Do they have friends? Do they have anybody? Are they depressed? What's their mental health, their social resources? Do they have money at all? Do they pay for anything, period, financial resources? Who's their primary care physician? Can I get them an appointment within 7 days because that's really what they need? Oh, you're booked up for 14? I guess I'll have to do that. Substance abuse. Do they have that kind of an issue? Are they interested in receiving treatment or for their addiction? What does the physician want them to do? How about the surgeon who did the procedure? They have crazy preferences. What does the physical therapist or occupational therapist recommend? Oh, by the way, I have to document their acuity so I can send it off to insurance to make sure that the patient doesn't get slammed with the bill after their hospital stay. Oh, and last but not least, what does the patient want? These are all things on the mind of every case manager for 20 patients, and they're assessing it over a very short time period of 2 to 5 days. So there's a lot they have to keep in mind. And if a community-based organization is too foreign to navigate, they don't have time to do a lot of deep digging. It's the reality of the situation that we work in every single day. It's overwhelming. So what we end up doing is we correlate insurance benefits with a discrete discharge plan. So if insurance pays for it, that's where we send them. Skilled nursing, home health with some DME or long-term acute care or whatever the issue, whatever it is. There's not a lot of time to do deep digging on, well, do they have resources to pay for a private caregiving agency? Or on a case-by-case basis, if that's what the need is, they do that. But typically, 80% of the time, we're thinking about what does insurance pay for? Skilled nursing? Great, you're going to go there. Everyone fits into a nice, neat, square box, right? No, but that's how it works. That's kind of what we have to work with because that's the system in which we live in. So, but now that things are changing up a little bit, we're moving away from this fee-for-service, payer-based model to a little bit more of a bundled payment world. Let's really find out what the right thing or what the needs of this patient are. We can start to get creative, and that's where we have our respite plan, our respite program, and I think it's exciting because it allows us to really address the gaps in care, the psychosocial issues that are often left unaddressed. So, to kind of sum things up today, from the hospital perspective, this is what we need from community-based organization partners. There are a lot of factors where we struggle with transitions. Right? Patients experiencing homelessness, I was really glad we started with that because that's a very complex issue. We can't just push people out to the street, but oftentimes they have a need that is pretty acute, and so that's a problem for us. Behavioral mental health, there's just not enough resources that are easily accessible, or there's long wait times, or it varies county to county, and there's not enough knowledge of how to access these things in the inpatient setting. Substance abuse is another big one. Memory care, there are so many issues for patients with Alzheimer's or dementia who aren't able to remember their care instructions or even take care of themselves, that's in a way that they deserve. And then ongoing health engagement is really critical for the rest of the patients who aren't experiencing one of these crises. Just making sure that they know how to access their PCP or really be engaged or understand how to really provide their own self-care. So if we're partnering with a community-based organization, it's very helpful if they can have a clear defined, number two, a clear defined service addressing one of those points, that there is some kind of it really does eliminate a barrier to discharge for us, and it helps solve a medical or a psychosocial issue in the setting outside of the hospital, because we aren't good at it. We're really good at taking care of congestive heart failure exacerbation. We're really good at taking care of these acute ill needs. We're not good at psychosocial issues, but these things are very important and do impact a patient's health. That's where we, I think, have a lot of opportunity to partner once a patient leaves, and that's where I think there's a really synergy. And we're not the expert, and I hope that you guys are, because this is where the needs are. So, number two, the case manager is strapped for time. So a program has to be very clear parameters. What are the hours? How do I I refer a patient to you? How do I know that a patient's going to get to you? What can I tell the patient to expect when they're there? And when can they come? Like step 1, 2, 3, 4, 5. Not loosey-goosey. If it takes a case manager too much time to understand, they're not going to read into it. They're going to go with the easy thing. It has to be easy. And it has to be easy for the patient to understand, because often these patients are very fragile. They're being given tons of information about their medications, their aftercare plans, their PCP appointments. This is a very new acute stage for them. They're very fragile. They remember like less than 20% of what they're told during that time, so it has to be very easy. And then the last thing is we don't close, so it's helpful if we have consistent access to you all as a community-based partner. And I'm really happy that Jamie from Bax is here, because we think have a very successful partnership that I'm glad that she's going to share. So that's all I have to talk about from the hospital perspective.
Good morning, everyone. Is this on? No. Should I? I'm really uncomfortable with microphones, so this one's good. Thank you. Thank you so much, Austin and Karen and Wendy, and to Margot, too. I now see Wendy's brilliance in setting up this panel, because it's very sequential. My name's Jamie Almanza. I'm the Executive Director of Bay Area Community Services, or BACS. It's so nice to be amongst family in this room. I'm going to take the opportunity to both share about the great partnership that Sutter and Austin and I developed over the last year, and also take the opportunity to share what it's like to be a community-based organization, a nonprofit, which many of us are in the room, to help our organizations and what it takes to build infrastructure to solve some of these growing and emerging needs. Let's see. So just very briefly, our mission as an organization, we've been around since 1953, born and raised in Oakland, and our mission is to uplift underserved individuals and their families by doing whatever it takes. In the last 3 or so years, we really as an organization decided we want to do more. We're traditionally a social service, behavioral health, homeless agency, and we knew, especially with the Affordable Care Act, that we wanted to participate as partners with the hospital systems and the healthcare systems. And so we took on a very internal process, a strategic process, to build our infrastructure that I'm going to talk about very briefly, to get to where we are at now, which is a new innovative program in partnership with Sutter. So our approach in the last 3 years, we implemented a practice called results-based accountability. It's really a healthcare evidence-based practice model to help us understand what we're doing, how much we're doing it, and how well we're doing it. Does it have the intended impact we need to have to our communities that we serve? This took a lot of heavy lifting internally. We had programs that we had limping along for many years that in retrospect were diverting us from our mission, and I think that's important to talk about briefly in terms of being a community-based nonprofit organization where there's such a heavy reliance on our services, and of course the payment models that Austin talked about in the hospital world are very similar in the nonprofit world, where we have to braid together the $5,000 grant and the fee-for-service and the in-kind donations. And how do you do all that and create very innovative, complex responses to what we heard from Margot this morning? One of our chief priorities is serving homeless seniors, and so it was nice to hear all of the data, and that transposes to the innovation with respite care that I'm going to talk about. But it took a lot of internal kind of reflection. It took sunsetting some programs that were weighing on us very heavily as an organization. And so for the funders and healthcare government partners in the room, it's just to say out loud that nonprofits are doing all of this simultaneously while also needing to build anew. We had an intention to make friends in the healthcare sector, so in the hospital sector. As an organization, we were always the call for Meals on Wheels when someone was getting discharged. Hey, I need Meals on Wheels. We were always the call, hey, I need care management. But we didn't have formalized relationships with our healthcare and hospital partners, and we really wanted to do that as an organization to create this vast system of care that we're talking about. And we had to really think about culture change. So again, as a traditional nonprofit, it's kind of about getting all these resources together to make it work. And we really had to think about ourselves as a business and a nonprofit business to really create the sustainability and what we owe to our communities in this transformation. So in the last 3 years, we really invested in IT infrastructure. So many of us in nonprofits, you know, how many people did you serve last year? Well, let me get my 18 spreadsheets and sit up at midnight trying to figure that number out. That's not acceptable if we're talking about what we're talking about in terms of knowing our populations and our priorities and who our communities are and what we're doing as interventions. We looked very deeply at programs. We, like I said, had a few programs that we weren't as effective in. And again, as a nonprofit with a mission, you never give up those things. And we decided to make room for what I'm about to share. And we started thinking about alignment towards performance as an organization. And so Austin mentioned kind of fee-for-service and the capitation and pay for performance. And we all know in our sector that that's where it's going, and to be strategically aligned to that in the future, even as a social service organization. Our biggest challenges, even today, remain accountability towards what we're doing, and accountability towards population statistics, and accountability towards really doing whatever it takes. One of the things that we're very focused on is eliminating all of the barriers we can, and that's what I'm very proud to share in terms of the remainder of my slides in terms of this medical respite program. Really creating access to care by saying things like, you can be an active substance user. You don't have to have any income. You can present and walk in and be welcomed without any additional burdens. We are a mental health agency and a behavioral health agency, and if we were an agency that said, you know, go get clean and sober first before coming to see us, we'd be out of business. 80% of our population are active or recurrent substance users. And so it's how do you create frameworks and models with just the lowest barrier? And I'll talk more about that. Austin also said the 24/7. We need admission or intake processes that aren't Monday through Friday from 9 to 5, excluding holidays. I was once at a homeless panel, and a gentleman got up and said, my mental illness doesn't stop at 5 o'clock on Friday night, and so I need to access you Saturday at 6 p.m. And so we really worked hard to kind of open ourselves up to be able to do so. And then a cultural adaptation to business, to new relationships and business partners. The healthcare, the hospital environment is a very different culture than a traditional social service nonprofit organization. And so there's a lot of learning that goes into creating partnerships where we're all serving the same and have the same ultimate mission and philosophy of helping people in our community. But there's a different dynamic based on what your organization is. And really accepting that, learning that, and changing your language to be able to partner together and create a culture of responsiveness. And so that's something else we've been working on. So in terms of partnerships and really the intersection of what we're here for today, one of the things that is really important to us as we start new programs and endeavors is to have true partnership. And that's with Austin and I over the last year. We have to have a partnership that shares data. You know, we all have had those partnerships where it's like we think we're doing a good job, but we don't know what the utilization data is on the other side. And also sharing risk, and then sharing rewards. So setting up payment methodologies where if we're taking on a pretty profound risk when someone discharges to us from an inpatient hospital acute setting, sharing in the rewards, which may be in the mechanism of payment structures, being able to access each other's programs and other interventions. And so I encourage us to think about, as we develop partnerships in our community, that partnerships are most authentic when we're sharing data, we're sharing risk, and we're sharing rewards. So in terms of the rewards we've had as an organization in the last couple of years, we've been successful in having contracts with healthcare entities, and one I'm going to highlight towards the end, including health plans, and really those are new revenue streams for our organization, and it's very important, I think, to diversify in terms of having different revenue streams, different payment methodologies and buckets, all around sustainability of our community and access. Also, in the last year or two, this respite thing's really caught on, and so we replicated our respite program in Solano County, and we've had tremendous outcomes across kind of different geographies. And as Margot mentioned before, the reason BACS kind of is now in Solano County is our community, our people are being priced out of Oakland. And so now we're up in Vallejo very strategically because we have the same clients that kind of can't afford to be here. And so we need to also be where they're at. So in terms of the actual project, I kept it mysterious until the end, but I did want to get through a little bit of that just in terms of kind of a day in the life of developing these things as a nonprofit. So we have a partnership with Sutter Hospital, and that's what I'm going to highlight. And Austin and I, over the last year or so, I think have been really developing this. And how it started, there's a need for homeless individuals, mostly seniors, who are in an acute inpatient setting and who need further care after discharge from the hospital, but also don't meet the necessity to maintain in that hospital bed. So BACS runs the Henry Robinson, or the Housing Fast Support Network, which is the largest, the single largest homeless single adult program in Oakland and Alameda County of its type. And so we had extra space in this building in downtown Oakland, and we also saw the trend of homeless individuals being discharged who still need a lot of help. So the double amputee that has diabetes, who is no longer meets the need for that acute bed, and as Austin said, the trend is discharges have to occur in that system for those reasons. But discharging back to the streets is irresponsible. And so there's a whole model and movement nationally called recuperative care, and it's also named medical respite. And so we came together as two organizations and said we want to really affect change, and we have space, and so we would like to create a model where we work with you, Sutter, to refer anybody that is homeless, who needs further care and support but is ready to discharge from an acute inpatient hospital bed. And the model is actually very simplistic and pragmatic, and is so profound in terms of who comes to our respite program. It is people with, it takes comorbidity to a whole new level. You know, it's people with 10 or 12 different diagnoses that are homeless, that don't have a home. And so they come and they stay with us for around up to 30 days. Sometimes it's 5 weeks, sometimes it's 3 weeks, and they recuperate in a safe, healthy place with wellness support, case management support, and prompts. You know, if someone needs reminders to take their meds, if someone needs help getting to lifelong, all those different things happen in that window. And the most important part is they're recovering humanely. They're not recovering on the streets. They're not having to change their bandages on the streets. They're able to do that in a home. And that's in essence the model. It's cost efficient for Sutter, as you heard in terms of the methodology there. It generates revenue into our organization that is differentiated from what we already do. And most importantly, it's the people we serve, and it's really another intervention within the homeless system of care. And so the specifics and numbers, we have 10 beds at this point with this particular model. They're continuously filled. We've measured we're at 97% occupancy. 95% have not had a readmission in the window of time we just talked about. and 89% leave with improvement in one or more life domains. The question I get all the time, and where this really challenged our mission initially as we were developing this model, is, well, what comes after those 30 days? Are you going to readmit people back into homelessness, back into the streets? And at first, philosophically, I really struggled with that question and that notion. And then I had to take a step back and say, if it weren't for respite, this person would be back in the hospital, recovering on the streets, and if it weren't for this, then it could be a much dire situation. While the people that access respite live with us, we're absolutely looking at what's next for them. I think we've all talked about exploiting family supports, and that's been our number one kind of intervention is, hey, can you move your mother back into your house who's had a bout with homelessness for the last 6 years and has been in and out of the hospital? And we do so much family reunification at this point with our market, what it is. And other places too. We're able to access, because we're part of the system, we're able to access shelter, we're able to access transitional housing, we're able to get people started on heavy wait lists for permanent supportive housing. And so that's kind of an unanticipated added benefit, that even though this model isn't to really step in and prevent future homelessness, we've certainly been able to do that. I think that's my cue to end. So I will stop there. I really appreciate being able to share this with you, and really, again, appreciate all of our partners in this endeavor.
Good morning, everyone. How are you? Good? Good. I'm Corinne Jan. I'm the CEO of Family Bridges. Family Bridges has been around since 1968. We are a health and social services organization serving approximately 10,000 Asian, limited English-speaking, low-income immigrants. We have 7 sites. We have our two largest programs are adult day health care, 2 adult day health care centers. We have a child care center. We have 2 drop-in well senior centers, and we have a social services center. So I come to you, though, however, with a lens as a geriatric nurse, public health nurse for 30 or more years, and also as a caregiver to a 96-year-old mother who struggles with dementia and other illnesses. So that's pretty much the emphasis of my perspective. So I'm going to describe about a wonderful opportunity that we had, Family Bridges, our 2 adult day health centers, to be part of a pilot project called the Community-Based Health Home that was funded by the SCAN Health Plan, and there were 7 sites, all of us selected across the state, adult day health centers, to be part of this program. So you will see that the home in the middle is where the adult day health center is, and what the idea is, and you will see, and let me point out that this program, this pilot was developed, the Genius was developed by the Alliance for Leadership and Education, which is the nonprofit arm of the California Association of Adult Day Services. So the home in the middle is the adult day health center, and what we did was, with the 7 sites, it was a new team-based model built on our 88C model, but with the goals to achieve healthcare reform for high-risk, high-cost persons who had limited health literacy and poorly integrated care. So there's the intentional, you can see the lines, but there's the intentional relationship buildings and integration of the systems. On the right is the medical community, and on the left is, the left is the medical community and the right is the community. And so this was a deliberate effort to make sure that a nurse navigator, that was the key to this whole program, a nurse navigator interfaced constantly and developed relationships and developed partnerships with the community as well as the medical community. So that meant that when there was an acute episode or there was a person in crisis within this program, people were communicating, people already had relationships, all those questions that Austin in the hospital point of view had for the discharge planners, we would be able to answer all those things based on the relationships that we have already made with the hospitals, with the SNFs, with the managed care organizations. So that was the key. So here's a more pictorial portrayal of the sort of more intimate relationship between the nurse and the social work department and the interdisciplinary team. And you will note that it's sort of more circular than linear, which means there's a lot of communications going around, much more than if it was linear. It's a high-touch, high-trust relationship between all, and you will note that the managed care plan is in that circle, the caregiver is in the circle, IHSS, behavioral health, all those systems are designed, the program is designed to include all of those systems in our care. So here's a tip, here's what the profile was for this community-based health home. We had 212 persons in the pilot. That was the unduplicated count. And I'm going to list the profiles, but I'm going to, indicate what were the risks associated with those things. So 8.2 average chronic conditions. And what we saw there was chronic conditions, but associated with very poor health literacy. Not only were there so many systems in their bodies that were affected, but the participants had very little knowledge of what they were, how they interacted with each other, what they could do to help themselves manage their illnesses. 10.5 average number of medications, and that meant a lot of times polypharmacy. They were seeing lots of physicians, 2 or 3 for the same problem, and then each doctor would be giving them more medications, and they would think that they were taking all the right things, but a lot of times too many and not the right way. 90% had social risk factors. All of them were 100%, at least 100% of poverty, poor housing conditions. Their immigration status was probably challenging for them at that point. They had language and cultural barriers. 86% were at institutional risks, and this is what Dr. Kushel was talking about, functional limitations. They were unable to care for themselves, multiple falls, and 100% were ADL-dependent activities for daily living. They could not really take care of themselves. 44% lived alone. 55% had used the hospital and or the emergency department within the last 12 months, and 50% had dementia or behavioral health diagnosis or both. So then, this is just a brief, wait, let me get my glasses, it's too small. The brief summary of, on the left column is our cohort. It was a sample of 94 individuals, and they were dual eligibles, and then by diagnosis. And then on the right column is the DHCS under research and analytics studies of their dual sample of 369 of their dual eligibles. So this is just to show you the frailty level and the risk levels of our cohort. And I will just say, like, for example, high blood pressure, 85% in our cohort versus a 37% in the DHCS sample. Alzheimer's disease, 46% in our cohort versus less than 13% in the DHCS sample. And much higher rates of depression and other mental health conditions in our cohort versus the DHCS sample. So Dr. Kushel had used the term, this is where the rubber hits the road. Well, to me, in my experience as a nurse and now as an administrator, this is where the rubber hits the road. This is where the difference between what a nurse can do at the adult day health level, or basically the community level, versus our nurse navigator role, is where it really makes a difference. If you think about the word transition for a minute, My mother, 96, who really has a hard time with executive functioning, she has a hard time going from her house down to the garage with me to the car. And so just a simple transition like that, if you can imagine the transitions that happen post-acute or before at the home where their person is getting sick, and then going to the hospital or going to the ER, and then having to deal with coming back from the hospital back to their home or back to the adult day health center or back to their housing situation. Imagine that kind of transition and augmented 3 times over. Transitions are the hardest psychological, emotional, physical things to deal with for all of us, but think about it when you're having a hard time functioning and you're elderly or you're homeless. This is where the nurse navigator position or other positions like this where there is enhanced case management makes a real difference in the triple aim, and it makes a real difference in quality of care, health care for populations, and in cost savings. So the hallmarks are that the nurse navigator, our nurse navigator who traditionally is in an adult day health center service, can now leave the center. Regulations, if you're a regular adult day health center nurse, cannot leave the 4 walls of the center. So our nurse navigators go out into the community. They go to the physicians' offices with the participants. They develop relationship with the doctors. They learn about the treatment plans. They try and work together to enhance the compliance of the patient's treatment plan. They go to the emergency room with either before, after, or during the emergency room visit of our participants. They talk with the staff there. They ensure that there's some kind of seamless translation between the information of the participant and the emergency room, and or at the hospital level. They're there the day they are admitted, and at the day they are admitted, they are already figuring out the transitional issues, meeting with the discharge planner so that before that person's discharged, there should be a way that all those questions that the litany of questions that Austin had are already known or answered before that person is discharged. Then they're in the home with the family when they're discharged, and back to the home. They're attending the ADHC center, or that's where the health literacy part comes in. They're there to order the DME to durable medical equipment or the catheter supplies, and they're working with the managed care organizations to coordinate case management for that person, the aftercare, the churning phenomenon between going from one institution to another costs Medicare $15 billion a year. And so you can see with this intervention of a nurse navigator or a nurse navigator-like role is where all these pieces and all these gaps and all these things are sealed in so that these transitions are not risking quality of life, quality of your health care, and not risking as many dollars because readmissions, they're trying to prevent the readmissions of the hospitals. Real passionate issue of mine. So then, this just shows the outcomes of the 2-year study of our community-based health home. And in 12 months, it showed reductions in hospitalization rates, 24.15, and emergency visits by 23.6%, and 30-day readmissions was 1.8% compared to a Medicare average of 20%. So I wanted to end up talking about the opportunities that we have discovered given our pilot project and seeing how the model worked and how it interfaced and what were the outcomes. And the opportunities are, well, I would like to mention that the Long Foundation, and I don't know if, I think Nancy Schillis is here, she's Senior Program Officer for Long Foundation, was so generous to allow us to replicate this community-based health home model in Contra Costa County and at Alzheimer's Services for the East Bay. So they've been funded for 2 more years. Also, it's our opportunity to try and replicate this model or model of other iterations at other settings, and that is where we're looking for startup money. The Alliance for Leadership and Education, which is this is the brainchild of, actually meets with the learning community that has been established through this project almost every week for the last 2 years. So they're continuing to monitor the new sites, continuing to learn best practices and tweak the model. And we also have data tracking and data sharing with different entities. And that's really an emphasis that I wanted, that Jamie brought up, that data sharing and information sharing is really, really important with relationships as well. So we have plans. Family Bridges has plans, and again, I'm going to mention the generosity of the Long Foundation. We were fortunate enough to receive a $1 million grant, 2-year grant, to morph our community-based health home to become a health home that is certified by the state of California, hopefully. And what we plan to do is, the health home is not necessarily an actual home, and it's not where people live, but it's where a lot of providers seem to live a lot. But we are actually going to develop a site at one of our clinic sites to have providers that are primary care providers, behavioral health, our adult day health center interfacing, nurse practitioners, and case managers. So we want to reconfigure the team that was originally part of the CBHH. We might be reconfiguring the nurse navigator role to be a cohort of LVNs, community health workers, social workers. We plan to include palliative care into that model, and something very exciting, because we now have the foundation of a community-based health home, and now we're able to branch out and try and expand it and improve it. So that was the redesign. So the priorities that we focus on, and that I just want to emphasize with all the programs that we're talking about today, is that they have to be person-centered. There is no way that you can deliver any kind of quality or achieve the triple aim without person-centered focus. It needs to be community-based, as you've heard. The enhanced complex case management is a must. In fact, that is the hallmark of this kind of program. And the complex case management comes from relationship building and the increased communication and the sharing of data and the sharing of experiences. The program has to be preventive in nature. Otherwise, everybody's going to be flooding Austin's hospitals right away, and not enough people are out in the community living their lives. And then I can see that people are anxious to make me move on. So improving health literacy is a priority, because that is where rights to self-determination and awareness is really important. And then, of course, equal access to all these services, and this is where we need to pay attention to social determinants of health. So, one last statement: if you provide quality service, you will be able to save dollars, and you will be able to achieve the triple aim. Thank you.
Okay, thanks to all three of the panelists. Now, we have about 15 minutes, so I want you guys to be writing questions and passing them forward. But I'm going to start off with a few, because I feel everyone here can see this value of our community services and medical care aligning. I mean, that we know this is the right thing to do moving forward. I think the incentives will help us from a financial perspective that the hospital's looking at, and from a best practice perspective for all of us, and the best for the clients. So aligning up like this, we can sit up here and talk about it. It sounds pretty simple, but while we're collecting questions, I want to start off with a few questions. One about how do you guys find a common language? Because I think when you're here on the community-based side and you're hearing CPT codes and HEDIS scores, and you're like, how do we align up with something that feels like a foreign language? So I wanted to just kind of, any of you kind of talk about, do you come down and make a crosswalk? Do you like have language retreats? How do you guys figure out how to talk to each other?
Well, first we pick up the phone. That's what happened with Austin and myself. There's that whole network, so we need introductions to each other first. We have to meet each other, and then we start talking. And then as we talk, then we bring other people into the network. But you're right, it has to be a common language. And there's the common technical language. And then there's the common systems that have to be put in place. So that's a real challenge. And so I know for our plan is that once we implement a good electronic health record, at least we're talking the same language that way through computers. I know we don't always have to communicate through computers, but I think the start is to have conversations.
I appreciate what you said. I'm a year into my role. My role is brand new, and I think I spent the first year asking a million dumb questions. I cover 16 hospitals across the Bay, and so Alameda County is but one of my counties, and I try to immerse myself in what are the needs of that patient population that are most often unaddressed, and then just start off with a Google search or talking to people like Wendy Peterson, who connected me to Corinne. And then go out and meet and try to put myself in their shoes. Who do they serve? How do they do it? What does that look like? And while I think it's hard for us to still collaborate with a program like Corinne's, I think that there's hope in the future to keep moving in that direction. Things like having an immediate discharge disposition with BACs was a low-hanging fruit. This is something that I know we can do right now. And while we still continue to transition and learn about what services look like, we can better collaborate across the continuum.
And I would say we add 5 new acronyms to every partnership. And that's really our world. Depending on what system you're working in, I was just kind of marveling. It's like even in this enriched discussion, it's the homeless system, the older adult system, the behavioral health system. Each of that comes with its own culture and its own language based on, and its own set of acronyms, believe it or not. And so it's just, I think, encouraging the seeing things and creating relationships. So Austin coming to see this homeless hotel as we're developing this program, and then us going to the hospital and sitting, it's like at the nursing station. It's just you get a whole different level of vibrancy and appreciation for that litany, the list that we just heard from Austin earlier.
So part of this coordination of language is one, I'm going to go through a lot of questions here, and thank you everybody, but this kind of jumped out at me. It's like case management, and every person up here has talked about it, but just kind of any strategies for a better form of communication. I mean, the way this is written, just so you guys know, it says, why can't hospitals let community-based case managers into the hospital to work with hospital social workers directly? So I think this kind of shows the frustration that while we're envisioning where we want to go, there's existing frustration. So I'd like to speak a little bit around particularly case management and coordination of case management services.
So there's a regulation called HIPAA. You might have heard of it. Makes information sharing very hard. We have a burdensome, crushing burden of regulations we have to deal with, and we can't just let people into the hospital to hear about every patient detail. In a dream world, it would be great. We would know the information was protected, but we aren't there, and that's just the reality of the situation that we are in. So that's kind of where we're at. We don't know how to share information well with even our other medical providers. We're getting better at it, but even to a SNF, or a skilled nursing facility where we send a lot of patients, we're just now refining our handoffs, let alone a community-based organization that we don't really understand. I'm just being totally transparent. It's hard for us to know what information will be relevant, how to limit and protect the patient information in a way that's safe, because we're held liable for that if things aren't done well. It's a new world that it's just challenging to face, but I think the regulations are definitely a major component of that.
Yeah, the patient can sign a. Yeah.
So, but I think the number of So I guess the process then, if you were to think through the logistics of it, do we take a list of hundreds of community-based organizations to every patient and say, do you care if one of them, I apologize, this is just how it is. We don't have the time or luxury. What I think there's opportunity for, though, I mean, they're in the hospital for 4 days, right? They move out into a skilled nursing facility where they're there for 2 weeks. I think that's probably a better setting where they aren't having millions of pieces of information thrown at them in the second to kind of collaborate more. I think that downstream we could look at those things. I apologize for the frustration, but it's just the reality of the scenario of the world we live in.
Except you are right, and I've been with this in my personal life and with my mother and with other patients, is that I have them sign an agreement individually to allow us to look at their health records, and then that bingo. But besides that, it's still, again, it's that relationship building. So if you've already had a relationship with a DC planner, or you have the case managers on your dial with the Alameda Alliance for Health, then these are the ways to sort of fastidiously get information and get the same, and have the same story be told, not 5 different people who go through like that game telephone. By the time it gets to the last provider, the story is totally different. So it really is about inserting yourself. And, our nurse navigators are pretty nosy people. Well, nurses are nosy to begin with, but they're inserting themselves so that because they are the advocates. So they know these participants so well. The participants come to us 3 to 5 days a week. So we know them probably better than most people.
I think, Corinne, if I could just say one more thing, a proactive approach would be much better than a reactive approach. An established program with Baxter, an established program with CBAS, where we have these things set up in advance, that's different than allowing people to come in and just troubleshoot on an ad hoc basis. So it would need to be something, if it's something that's set up in advance, we can have everybody vet it, be comfortable with the impacts to it, much different. And I think is much more successful because we can then relate to patients what this means.
Can I just add one thing? The term case management, it in itself is a language question. Every participant that comes through BACS needs case management. It's an access question, and case management could mean a phone call once a year to make sure the person's still there. Case management could be daily, 24-hour, taking people places, getting people ID cards, getting people access. And so I think our system, through these efforts, needs to really quantify and qualify. And right now, I think case management is siloed because of funding, because of vulnerability indexes. And I do think in terms of the HIPAA stuff and the being really assertive as case managers, someone could go into the hospital and choose not to tell the hospital they have a case manager. And so I think it's just about trying to be as assertive as possible within this realm of what is case management.
And one of the things I want to point out is we're fortunate Austin's brave enough to come out here and talk from a hospital perspective. And I think it's important for us in the community to kind of self-reflect on how complicated and often fragmented our system feels to someone. And there's a lot going on that's hard to describe.
So hard to describe, that's a good phrase, because case management, care coordination, care management, all of those things are happening at all different levels. But where, again, I'm using this crazy term, rubber hits the road, is if the care management, case management, enhanced case services is face-to-face. And that's where the difference is made. So, and not everybody can do that. The large health plans, the hospitals can, but through all phases of that person's transitions, there has to be some kind of face-to-face contact. So that's where I can see all of our systems working together, that there's somebody that is able to do the face-to-face and then work with the ones who are in the hospital systems or the managed care organization systems, so that we're all working together, but there has to be that person-centeredness in there. So somebody's got to do that part.
And this question's perfect for that, and I really want to address this, because this is someone in the audience writing, it's like, we are getting way medical here. I mean, and everything we're saying is medical, medical, medical. And we've got to also realize that these are whole people, but their question is basically, how are we going to preserve services that are not medical? They're just as valuable. And I think we all believe that, but it's a point that we have to make sure that this panel was about the intersection of medical and community, so we have focused on that. But the value of what people do, people are in the hospital maybe 2 weeks a year, well, hope not, but 2 weeks a year. What are those other 50 weeks? They're at home, they're enjoying, they're dancing, they're walking, they're singing, they're playing ukuleles, whatever. That we have to value the whole person's perspective. No one up here is dropping their other services because they're working with the hospital. You know, so we're just trying to make sure that we're being inclusive with that.
Preserving not only choice, but not going into a medical model. So much that we're looking at our services, and once they come from one part of the service and going back into the community services to preserve that choice. But what model are we looking at to join all these services? And is it strictly into the medical model? Because we're coming from that as hospital providers, and we as community partners need to find ways to work together so that we don't just preserve that medical model and that we have a community choice model.
Yeah, I think that's, thanks for reframing your question. But I think everyone in here, you know, we want to also be exploring that value of being in the community and of consumer directed. But that's what this panel is kind of about. But I just appreciated that question.
When you wait to the next panel, you'll see that I think Scott's probably going to talk about whole person care. Then you'll see that there is emphasis from at the state level and the federal level to emphasize the whole care, the whole person.
And I think that's such a great frame. And I think for BACS as an organization, 99% of our services, if not 100%, are in the community. And the medical model, we're a social rehab model by philosophy and mission. And so this new intersection, we've been in and out of hospitals with our participants for many years and are much more on the preventative framework to avoid that situation altogether. I think for me as a nonprofit leader, it's about trying to break down the walls of what goes on and kind of penetrate that hospital system, only to really keep people out of the hospital. And so I think that frame is really important in terms of why we're all here today.
There was a question I thought was kind of interesting about the role of skilled nursing facilities as from the hospital perspective as far as utilization now or in the future.
So I think skilled nursing facilities are unfortunately being overutilized as a resource to address the lack of affordable housing in the Bay Area, and we are often faced with incredibly long lengths of stay in the hospital trying to find resources as for like a custodial skilled nursing facility when really the patient needs a house with some supportive services, and there's just not enough of those resources to do it. And I think SNFs are wonderful, they can do great things, but they are too expensive to be the housing solution for the Bay Area. And I wish that there was something, if there was a housing partner out there who could help me do wraparound case management with IHSS, let's talk. So that's one major problem we are faced with at every single hospital in Northern California.
Well, time?
Yeah, that's fine. No, okay, I've got 3 minutes.
Okay, so, well, again, and I'm looking at Linda Trowbridge and Diana Garrett and Marty Lynch, who the programs that are designed like ours too at the adult day healthcare level is prevention is where that prevents that SNF institutionalization. So the more we are emphasizing prevention and health literacy, the less that we have to depend on the skilled nursing facility in the first place.
And so we just have time for one more question, but again, we'll collect these questions and see if we can post them on the site or have Wendy go through them. But one of the other questions talks about a word that we've kind of been throwing around up here, and it's about risk. So financial risk, client satisfaction risk, just from different perspectives of what we're talking about. And I think one was specific around, are you being paid by risk indicators? So that was the actual question, but then it also talked about just defining what that means.
I can start. I think in terms of global risk, I think as a community-based organization, again, we're behavioral health, homelessness, and aging, and so inherently there's a lot of clinical, client-related risk in our work. We run crisis residential housing, all the way through the system, and we sign up for that to care and take care of the populations we serve. So I'm actually, and I think our organization is comfortable with the client-related risk, and I think that to be in this work, I think you have to have a certain level of that comfort level, or else I think that's where you then see policies and systems get more conservative and closed up. And so that's really important for me philosophically, is to work with people that's who we work with, is people with risk. Homelessness is a risk, all of the kind of behavioral stuff, et cetera. From a financial risk-taking perspective, we as an organization have gone through ebbs and flows of financial challenges over the years, and I think that's what I wanted to cover in my presentation, in terms of it is a risk to take on a program for our community that is grossly underfunded. And for BACS, as a kind of historical 65-year-old organization, a program almost completely bankrupted us, and it was all in the good and the heart of doing this work. So we've now shifted our risk-taking to more of a sustainability risk-taking method, which is to serve the same people and do the same type of work, but to really find partners that are going to share the financial risk. And I think government sometimes shares a lot of that financial risk, and I think that's what I ask the leaders in the room, is really for whether you're government, whether you're a community-based organization, nonprofit, whether you're a hospital or a health plan, it has to be shared risk, shared reward for these community-based organizations to not only be here kind of trying to stay open, but to thrive. And I think that the partnerships and deals we look at now, that is our kind of baseline test, is we're not just going to say yes and try to scramble. We're going to say yes, and we're going to do excellent work and guarantee outcomes, and with those outcomes we're going to need to get compensated for it.
So when I talked about risk earlier, I was specifically talking about financial risk. I think we can all agree the healthcare system is broken. I by no means am advocating this is a perfect solution, but I'm an optimist and I like to get things done, and I think that we can get there. I want to talk a little bit more and give an example about financial risk and how things are changing for the healthcare industry. There's a program called CJR right now, put forward by CMS, the Medicare federal agency. CJR places health systems or hospitals at risk for a joint replacement, a hip or knee replacement, for that surgery, day 0 through 90 days afterwards. They're in the hospital for 3 out of 90 days, yet we are at risk for what happens to that patient for the next 90 days. CMS has given us a goal where we don't control 87 days out of 90. So we are now collaborating with providers in a way that we never have before to make sure the patient is taken care of. And if the issue, the risk of readmission, doesn't stem from an infection of their surgical site, it stems from their substance abuse, we're going to address that in a way that we haven't ever before. And I'm really excited because I think this is the first of many bundles to come, where we're looking at innovative partnerships. We're really getting into the deep crux of what does a patient need, not what does their insurance cover. So this is a new shift. I'm really thrilled. I'm at time right now, but that's what I mean by risk. Thank you.
So I think we have a lot more to explore here, but we are going to move on. But I'm just going like, what do you mean by payment risk, 90 days? But I think this is going to leave us today like we started, saying we'll have more questions, we have a lot more work to do, but just as food for thought, let it sit, and we'll keep moving. But thank you, panel. We're going to move on to the next one.
Not the ones that you asked.